Good morning, everyone. Welcome to today's class. Today, we are going to discuss about carcinoma of left colon. Now, in the previous 2 weeks, we have discussed about carcinoma of rectum. Last week, we have discussed about carcinoma of the right colon. The presentations of carcinoma of left colon is slightly different than that of the right colon. That's why we are going to discuss it on a separate day. We get left colonic malignancies are far more common than the right colonic malignancies. That's why I think a separate discussion class is necessary for this. So, but previously, before we go into left colon, let me tell you what I mean by left colon. By left colon, I mean from the splenic flexure. If I get a chance, let me try to show you. If this is the colon, right? By left colon, I mean that starting from the splenic flexure up to the rectosigmoid junction. That means the descending colon, the sigmoid colon, up to the rectosigmoid junction. So these any malignancies over here usually have very similar features. Okay, so let's start with the particulars of the patient. As usual, like any malignancies, the age is usually more greater than 50 years. But you must always know that if the patient is below 50 years, doesn't mean that he does not have a malignancy. That's because nowadays many younger patients are having malignancies, maybe due to familial cause or the environmental causes. Environmental causes, I mean by the pollution that we are having nowadays. Pollution and other problems, formalin and different preservatives that we take, our food habit has changed. So these are the few factors which are resulting in the chances of malignancy in a lower age group. Male patients, like all solid organ malignancies, are more common in male patients, mostly. Not all. For example, breast cancer is definitely something which is more common in female patients. But other than that, many of the solid organ malignancies are more common in the males. Occupation may be important. Those who are chronically exposed to carcinogens have more chance of having malignancy. This is the presenting illness. You can certainly write the way you want it. This is one way to write it. According to the statement of the patient, he was reasonably well about 6 months back. Then he noticed painless bleeding during defecation. Now, why we talk about painless? Painless because if you remember, most of the bleeding that takes place are due to anorectal causes like hemorrhoids, fissures, and piles, and other problems. Now, fissure, to differentiate between fissure and other causes of bleeding, that's why I said painless. It certainly gives you an understanding that it's most likely not a fissure. The blood is usually small in amount. Why small in amount? Why is it important? For example, if the bleeding is from hemorrhoids, it would be profuse, usually profuse bleeding, and usually fresh bleeding. In case of rectal cancer, there may be fresh bleeding, but usually not profuse. So that's why I said small in amount, mixed with stool and mucus. So this gives you an understanding that the bleeding had certain amount of time to mix with stool and mucus. That gives you an understanding that it probably is not from the most distal part of the colon and rectum, probably something more proximal to the rectum. because rectal bleeding and anorectal bleeding are usually fresh bleeding. So it can be somewhere from the sigmoid colon or maybe slightly more proximal. Occasionally clotted blood is passed. That also gives you an idea that blood had the time to get clotted. This also gives you an idea that it may be somewhere from the sigmoid or the descending colon. More proximal bleeding, for example, had it been cecum, more proximal than the splenic flexure. If bleeding is from in this area, you don't actually see red blood, and it would be very difficult for the patient to figure out whether this is bleeding or not. But more distal bleeding, that is from the splenic flexure to uh, sigmoid colon or the rectosigmoid junction, there is a slight bit of blood which is usually mixed with stool and mucus, and sometimes they can be clotted. Proximal bleeding you cannot see, especially in the right colon. The bleeding in the right colon you cannot see. That's why patient comes comes to you with the history of unexplained anemia. That means bleeding is happening. Bleeding is happening in the colorectal area, but you can't see the blood. It is altered, it is changed, it is mixed with stool, so it cannot be seen. But the bleeding from the left colon can be seen, but it is usually mixed with stool and mucus and sometimes clotted. For the last 4 months, he is having alteration of bowel habit. Now, this is sometimes a little confusing term. You don't understand what this means. Alteration of bowel habit can be of two types, really. Number one, for a patient may be having normal bleeding, normal stool for many, many years, for maybe 20 to 30 years. Suddenly there is a change. It may be constipation or it may be diarrhea. Anything is alteration of bowel habit. Constipation is not the only alteration of bowel habit. For example, patient says that for the last 20 years, I have been going to the toilet 1 to 2 times with normal consistency. Suddenly my bowel habit has changed. How it has changed? It can be change in the consistency. It can be having constipation. It may be diarrhea. Or it may also be something like the patient says, I used to go to the toilet 1 to 2 times per day, but now I am going to the toilet 5 to 7 times per day. This is also an alteration. Alteration of bowel habit can be in the form of consistency, or can be also in the form of frequency. So, what is happening to this patient? He is having alteration of the bowel habit in the form of constipation. Remember, it can be either constipation or it can be diarrhea. Then we'll talk about the frequency. Previously, patient passed stool, normal stool, 2 times a day. But for the last 4 months, he is constipated and passes stool once in 3 days. So you can understand this patient is having an alteration of bowel habit, both in the form of consistency and frequency. Next, what is happening? And the patient is taking purgatives. Maybe he's taking some sort of stool softening medications like lactulose or something like that, or maybe spagula husk, but it is not helping. So that means the problem he's having, it is refractory to the medications. He also complains of colicky abdominal pain, which is relieved after defecation. That means, if this is colicky, that means he is having some sort of obstruction. He has no fever. Fever is an important cause because any type of obstruction, you always must consider, is there any infective cause like tuberculosis, is there any inflammatory cause like Crohn's disease. So these are the things we would like to consider, but especially Crohn's disease, you may or may not have fever, but fever is an important characteristic of tuberculosis in Bangladesh, right? Vomiting or abdominal distension. So we are just trying to check whether the patient had complete obstruction. He is having colicky pain, that means he's having partial obstruction. but no vomiting or abdominal distension. That means complete obstruction hasn't yet taken place. He is having a good appetite and no weight loss, meaning that it's still most likely an autosystemic disease. Most likely it's still localized, whatever the problem is. The bladder habit is normal. There's no other significant systemic symptoms. Now, you can certainly, if you think that this may be a case of malignancy, what you mean by systemic symptoms is, are there any features of metastasis? So you can take the history, for example, whether there is any dyspnea, that's in lung problem, dyspnea, or any hemoptysis, whether any jaundice or any hepatic problem, whether there's headache, bone pain, or etc. These are the things you'd like to take history of. Certainly, past history is very important. The patient is having bleeding, meaning he has anemia. That's why patient has had a history of blood transfusion. Any history of colorectal malignancy. As you know that if patient has a previous colorectal malignancy, there is always a chance of metachronous disease. Inflammatory bowel disease. You know that ulcerative colitis and Crohn's disease, they rarely turn into malignancies. Previous history of polyp. Some patient comes to you with and gives a history that he has repeated polypectomies previously. So this patient has a chance that one of the polyp were missed and the polyp may turn into a malignancy. Personal history, that's of course all the bad habits. Patient may have, smoking, alcohol, poor diet, low fiber diet, high fat diet, low physical activity. These are all important factors resulting into malignancy. Family history of hereditary disease must take. Family history of colorectal malignancy, especially when we understand it's more of a familial disease when the first degree relatives are affected, especially at a younger age. Again, young inflammatory bowel disease in the family. HNPCC, APC. APC means adenomatous polyposis coli, and HNPCC, hereditary non-polyposis colorectal cancer. If we get some time, I will probably discuss about these diseases in a future presentation. Socioeconomic status, you should take the history. Immunization, not very important, but should take menstrual history. If this is a female patient, you must take menstrual history. General examination, usually distal colonic malignancy patients are not very symptomatic, but definitely may look ill looking. Usually there may be anemia present. Other than that, there's usually not much findings in general examination. On local examination or abdominal examination, again, there may not be any finding until and unless it's very advanced. There may be a lump, not visible. Usually they are not visible. There may be a lump. If there is obstruction, there may be abdominal distension. Digital rectal examination, the finger may be smeared with blood. These are the things. If you get, usually in left-sided malignancies, bleeding, alteration of bowel habit, and sometimes abdominal distension, these are the only features. We rarely get a lump, but yes, we may get an abdominal lump. So if you remember, the lump is usually in the left lumbar region, right? In and around the flanks. The lump should be somewhere around here. If this is the abdomen, you definitely must check the size of the lump. Most importantly, the fixity, whether it is fixed or not. Very important. Must check for fixity. Usually they are mobile side to side if it's a colonic malignancy. If it is fixed, that means more further advanced disease or irresectable tumor. Always remember fixity. So fixed, it means irresectable tumor. Irresectable tumor, that means better go for chemotherapy. Before go for new adjuvant chemoradiotherapy, which may downstage the tumor, and after that you do the surgery. Always remember, if it is a lump in the abdomen, a lump, if you can palpate a lump, it's an advanced disease. And if it is fixed, it's an irresectable disease. It's an irresectable disease. So these are the things. That's why we should be a very good, very efficient in abdominal examinations. Always you get a chance to examine up any patient's abdomen, whether it's normal or abnormal, always check it. And if you have time, just palpate your own abdomen. That's also a very good practice. So salient features. Try to write the salient features as short as possible. You can certainly write the way you want to write it. This is one way of writing it. Mr. X, 68 years, a farmer from Borishal, was admitted to the hospital on this date with the complaints of parectal bleeding for 6 months, alteration of bowel habit in the form of constipation for 4 months, colicky abdominal pain, relieved by defecation. Why is it relieved by defecation? It's actually when the stool passes, when the intestinal content. For example, if this is the colon and if this is the malignancy, which is narrowing the lumen, when the stool passes through this and patient can defecate, he gets relief. Pain is relieved. That's why colicky abdominal pain is relieved by defecation. He has no sign of intestinal obstruction, local advanced disease, or distant metastasis. What do you mean by locally advanced disease? If locally advanced, if the patient can palpate a lump, if the patient says, I have a lump in my abdomen, so that's by history you can understand disease is locally advanced. Certainly, any sign of obstruction is actually also sign of locally advanced disease. Distant metastasis, if the patient says jaundice, if the patient says respiratory distress, hemoptysis, headache, bone pain, those are all histories which is supportive of distant metastasis. So you should talk about that as well. The patient on general examination is anemic because of the blood loss. On abdominal examination, now remember, sometimes the patient may not be able to palpate anything, but on abdominal examination, you may be able to palpate a lump. Usually, remember, left-sided lumps are very uncommon, but definitely you can get lumps. So if you get a lump, how do you describe it? On abdominal examination, he has an intra-abdominal lump. Remember, always during examination of any lump of the abdomen, make sure you do the head raising test and the leg raising test to make sure whether this is an intra-abdominal or an extra-abdominal lump. In the left lumbar region or the flank, excuse me, measuring the size is about 5 into 6 centimeters, irregular in shape and surface, hard, very important, but mobile. So mobile, this means probably an advanced disease, but maybe resectable, which is not bimanually palpable or ballotable. Remember, usually if it is a kidney, if it's a renal origin, they are bimanually palpable and ballotable, as because this lump is in the lumbar region. It is, we certainly like to make sure that whether this is a kidney or renal disease or not. That's why we should go for bimanual palpation and ballotability of the lump. Now remember, if this is a very large lump, they are usually bimanually palpable. They do not have to be a renal disease. Does not move with respiration. Sometimes you may confuse yourself with spleen as well. So spleen moves with respiration, but the colonic growth never move with respiration. On digital rectal examination, finger is smeared with blood. So provisional diagnosis, the patient is having a left-sided lump. The patient has a alteration of bowel habit, parectal bleeding, which is supportive of a malignancy. The patient is also having left abdominal pain. Patient has a left-sided lump. So all these things, you're probably thinking that this is a case of carcinoma of left colon, or you can say descending colon, or in the upper sigmoid colon, maybe. Differentials, always remember differentials according to finding. It may be tuberculosis, it may be Crohn's disease. even diverticular disease, which is not very common in Bangladesh, but if you go to a colorectal surgeon's office, you'll definitely find many patients with diverticular disease. Lymphoma, which is again a rare possibility. Retroperitoneal tumor, again a rare possibility. Now, these are some of the investigations. Certainly, digital rectal examination is not really an investigation, so you don't have to write it in under investigations. Fecal occult blood test. Now, these are not very important, but many of the students have been asking me for the last few days about this. The fecal occult blood test is, we do not really do this investigation if the patient, because the patient is bleeding, right? So it is not occult blood anymore. For example, last day when I was discussing about rectal cancer and I said bleeding, you asked me, many patients, that would we do a fecal occult blood test? That means, you understand, occult means hidden, right? Now, if the patient is already bleeding, you don't want to do a fecal occult blood test. I mean, this sounds very silly, right? So don't say, if you can see pararectal bleeding, never write fecal occult blood test. This is wrong. But if it is a right-sided, colonic malignancy, and if you do not see any blood, you can do that. You can do that. But this is, remember, this is for screening purposes. Nowadays, much better investigations are there. So we do not do this investigation nowadays. But you certainly have to know about it. Uh, you can check it from internet or any other place. I don't have a lot of time, that's why I will not discuss this today. But fecal occult blood test, you have to know about it. So read it from any books. Anemia, you have to check the blood. The patient has anemia. Yes, sir. Again, not very important, but may increase, give you an idea that something is going on. Carcinoembryonic antigen, definitely. Very important. Must check it. Because remember, carcinoembryonic antigen, what we want to check it, because when the patient comes to you at presentation, we want to check the baseline, right? Then after treatment, which may be chemotherapy or which may be radiotherapy, whether it has decreased or increased, you want to check it. And then follow up. Again, you want to check it and follow up, because increasing CEA level means recurrence. Increasing CEA level after operation or after chemotherapy means recurrence. Recurrence. Plain chest X-ray, again, plain X-ray, which is of abdomen, not chest, of abdomen, which may show signs of obstruction and dilated bowel if there is obstruction. Chest X-ray for metastasis. Barium enema, again, we don't do it, but for theoretical purposes, you must learn about it. Apple core deformity. Apple core deformity. What does it mean? For example, this is the normal colon, let's say. And if you do a barium enema, you'll see that the barium is all over the colon, right? It's something like this. Barium is all over the colon, right? But if the patient has a tumor, then what are you going to find? You are going to find something like this. So that's as if someone has eaten an apple, right? This is called the apple core deformity. Ultrasound, again, another investigation which is very available in Bangladesh and everywhere else, so you must talk about it. But CT scan of the abdomen is actually the most important investigation for staging purposes. MRI is again something that can be done, but CT scan is the best. Now, the most important investigation is actually for left-sided colonic malignancy is colonoscopy. You can certainly talk about sigmoidoscopy, but if you want to, because ultimately you'll have to check for any synchronous tumor as well, right? Because you want to check the whole colon, right? For example, a left-sided colonic malignancy is over here. So if you do a sigmoidoscopy, this checks for about 60 centimeter. So it will usually go up to around the splenic flexure. So this tumor can be picked up by sigmoidoscopy, but you also want to pick up any synchronous tumor or any polyps, right? So you will one way or the other do a colonoscopy. So better go for a colonoscopy which goes for about 1.5 meters and which can check the whole colon. So the best investigation for a left-sided colonic malignancy is colonoscopy, but you can certainly go for sigmoidoscopy, which is similar to a colonoscopy but can only see up to 60 centimeter. If the patient has obstruction, go for a virtual colonography, which we have discussed in the last presentation. Virtual colonoscopy is something which is very exciting for most of the colorectal surgeons nowadays. So you may get a question from that. Again, fecal local blood test, not very important. Double contrast barium enema, that is water and barium both are inserted into the colon. Digital rectal examination, which is not really an investigation. You don't have to talk about it. Again, endoscopies, as I've just talked about, the sigmoidoscopy sees up to 60 centimeter. It's an important investigation and which can be used to take the biopsy. Sigmoidoscopy is cheaper, much cheaper than a colonoscopy, so it is more available. It is more available, right? So certainly you have to know this and you can discuss about sigmoidoscopy. There is also another rigid sigmoidoscope which can see only up to the proximal or just few centimeters into the sigmoid, so which is not very helpful again. So if you want to go for it, you must go for flexible. The flexible sigmoidoscopy. Colonoscopy is the investigation of choice. Should be carried out as 3% of the patient may have a synchronous tumor. Very, very important. You do not want to miss out on a synchronous tumor if you want to do this surgery. Colonoscopy, these are some of the things about colonoscopy. Just remember that there is a chance of perforation. There is a chance of perforation, which you must talk about during taking the consent. Consent, must take a consent before do a colonoscopy. Very important. Sometimes, rarely, it's failed procedure because you cannot reach up to the cecum. So that can also happen. Rarely. It requires a bowel preparation. These are the colonoscopic images, as you can see over here. These are the malignancies. You can see the blood, the bleeding coming out. And when you see such a problem, you take a biopsy. Remember, nobody have cancer. I'm sorry. Nobody have cancer until the pathologist says so. It's very, very important. Never go into surgery without confirming, because sometimes if you look into the colonoscopy and you can see a malignancy, you are sure that it's cancer, but without biopsy, never go into surgery. Make sure you have the biopsy and it's proven. Now, if this is a malignancy, that's how you see from a colonoscope, you want to divide it into 4 quadrants and take at least 2 samples from each quadrant, and a few samples, maybe 1 or 2 samples from the center. Ideally, the best samples comes from the periphery. This is the best place because centrally it is sometimes necrosis takes place and there is not much representative tissues over here. So make sure you take your tissues from the periphery. Again, CT colonography. This has similar preparation like colonoscopy, but even if the patient has obstruction, you can do a CT colonography and may get polyps as small as this. In this case, it has been expanded by giving air. Air has been inserted through the anus and it is expanded. Chest radiograph. Again, look at here, is a pulmonary metastasis. The double contrast barium enema. As you know, we have used in double contrast barium enema the barium and air. If you go and see, sometimes we use the air, just we use the atmospheric air. There's no special air is being used. It's just use the atmospheric air. You can use the pump used for the tires of the bicycle. That pump can also be used. It's just atmospheric air, just normal air, nothing different. And this is barium. Here you can see the apple core deformity over here. The apple core deformity. CT scan. Again, another important investigation. Here you can see the liver metastasis, multiple liver metastasis. Now remember, how can you differentiate between a metastasis and primary hepatocellular carcinoma? Usually hepatocellular carcinoma are single and metastases are multiple, usually. Here again, you can see the left colon, there is a malignancy over here. Here again, you can see the cancer. So as you can understand, CT scan is very, very helpful. What it can show, first example, the tumor, any metastasis, especially in the liver, any ascites. If it is advanced disease, sometimes that can also be shown. Sometimes lymph nodes can also be seen. But usually the tumor, the metastasis, and ascites can be seen very clearly in CT scan. Now comes to the treatment. Remember, all treatment depends on the stage of the disease, right? Stage of the disease. What do you mean by stage? Stage means 1, 2, 3, and 4. These are the 4 stages. 1 or 2 means it is local disease. 3 is locally advanced disease. And 4 means distant metastasis. So in case of 1 or 2, we go for surgery. In case of 3, ideally we go for neoadjuvant chemotherapy. And in case of 4, we go for chemotherapy or palliative therapy. Because when it is metastasized, that means there's no chance of cure. It cannot be cured. So all we can do is whatever time the patient has, make him comfortable, and this is called palliative therapy. So for the decision to be made, we need to have a medical oncologist, the radiation oncologist, they have to be present, the radiologist who will assess the CT scan and the other investigations. The pathologist will investigate the histopathological report, and together everyone will decide what is the best course of action for this patient. Anesthesiologist will check for the fitness of the patient, whether the patient is fit enough to be treated, to go for surgery, or to go for palliative therapy. Nutritionist must be there as well, especially in case of advanced disease. What is the type of nutrition the patient needs? Remember, goal of treatment. Again, what we have just discussed is defined by the stage and type of cancer. Stage is 1, 2, 3, 4. Type means, for example, if it is a poorly differentiated cancer, you need greater resection margins, right? Goal of treatment of early disease. In very simple terms, we remove the tumor. That is the thing we need to do in case of early disease. But if it's an advanced disease, stop the growth and maintain quality of life. Just what we have discussed right now. Now remember, surgery. Surgery is the only hope. Surgery is the only hope for cure for the cancer and palliation. Whatever it is, surgery is the mainstay of treatment. Surgery is the mainstay of treatment. What is the principle of surgery around here? Now, what is the principle? For example, if a particular patient, let's say this is the colon, and the patient has a tumor over here, right? Now, what is happening here? The tumor is spreading in all directions, right? About 5 centimeters, especially in the proximal direction. They spread more in the proximal direction. So we try to take about 10 centimeters proximally. Tumor is also spreading through its lymph nodes and through its vessels, right? So, and tumor is also spreading circumferentially in the mesocolon, right? So what are the things that we want to remove? We want to remove the whole tumor with proximal 10 centimeter or at least 5 centimeter and distal 5 centimeter of the tumor together with lymphovascular, together with its lymph nodes and vessels. So this is what we want to remove. We want to remove en bloc, that means continuous in one go, as a whole. En bloc, removal of the tumor with proximal and distal tumor-free margin, that is negative margins. Proximal and distal tumor-free margins with lymphovascular clearance, together with lymphovascular clearance and together with its mesocolon. So we remove en bloc removal of the tumor with its mesocolon, with proximal and distal tumor-free margins, meaning proximally at least 10 centimeter, distally at least 5 centimeter, together with lymphovascular clearance. This is called oncological clearance. This is called oncological clearance. Remember this thing. This is very, very important. How we achieve oncological clearance? We remove en bloc removal of the tumor with its mesocolon with proximal 10 centimeter and distal 5 centimeter of tumor-free margins together with lymphovascular clearance. This is called oncological clearance. And after that, we anastomose the proximal and the distal part. So this is very, very important. We certainly have to go for the bowel preparation. Remember about the bowel preparation, which is a bit of controversy is going on nowadays worldwide, whether to go for bowel preparation, but usually we go for bowel preparation around about 3 days. 2 days is also okay. On the 3 days before operation, we go for low residual diets. 2 days before operation, we go for liquid diet. 1 day before operation, we continue the liquid diet until the evening. And then in the evening, we stop, keep the patient nothing per oral, give the patient an enema, usually in the evening, so that the patient can clear his bowels before nightfall, and at around about 10, the patient can sleep. There may be different protocols of this in different hospitals, but the principle is the same. We go for low residual diet, then liquid diet, and then NPO the previous night, and give the patient an enema, and then we go for operation. Now remember that Nowadays, many surgeons do not prefer bowel preparation. They do without bowel preparation or mechanical bowel preparations. So remember that, but most importantly, you have to know the principle of what is exactly happening. Certainly, you do not give any bowel preparation if there's complete obstruction. If the patient has complete obstruction, you can go for an enema, but never go for any oral preparation. Deep vein thrombosis prophylaxis, all these things is very important. Although in Bangladesh, it is not done very commonly, but it is very important. Surgical procedures. Now remember, the new term that is used nowadays is early ligation of the vascular pedicle. What does this mean? Now, if you remember this picture, now look at this. This is the vessel, right? Now, if you start handling the tumor before ligating the vessel, what happens? The tumor cell may spread through the vessels, right? That's why at first you ligate the vessel. Now, which vessel are we here we would like to ligate here? Now, if this is the colon, now, for example, now let's say the tumor is somewhere around here in the left colon. Now, where does it get its blood supply? If this is the inferior mesenteric artery, let's say this is the aorta, and this is the inferior mesenteric artery. One of its vessels, the left colic artery, is supplying it, right? And the inferior mesenteric artery here continues at the superior rectal artery. So what is happening? Now you have to go for the lymphovascular clearance. That means if this is the tumor, you either, best way to do is ligate the left colic artery at its origin. Now remember, some surgeons nowadays also ligate the inferior mesenteric artery as well. But if the tumor is coming from the left colon, ideally we ligate the left colic artery, which is a branch of inferior mesenteric artery. So before mobilizing the tumor, you ligate the inferior mesenteric artery, you ligate the left colic artery at its origin from the inferior mesenteric artery, or IMA. This is what is called high ligation. And the thing what we have said, that early ligation of the vascular pedicle. Before mobilizing the tumor, you first ligate the artery. So there is no chance of dissemination. This is called early ligation of the vascular pedicle. This is also part of the general principle of surgery. After ligation, then you mobilize the left colon from the sigmoid, the splenic flexure, and as much as possible. Keep the middle colic artery and left branch of the middle colic artery. Remember, the middle colic artery is a branch of the superior mesenteric artery, right? It has two branches, the left and the right. So the left branch would give through the marginal artery of Drummond, will supply the blood to the anastomotic site. So we remove the splenic flex from the splenic flexure up to some part distal 5 centimeter, and we anastomose these two parts. This may be a little difficult, but you'll understand this thing. So we remove this part according to oncological clearance. So whatever is remaining is the transverse distal part of the transverse colon and the sigmoid colon. Now remember, these two parts are mobile. So you bring them close to each other and do the anastomosis. So you bring this part over here and this part over here, and you do the anastomosis like this. So what we are doing, we are resecting the tumor followed by anastomosis between the transverse colon and the sigmoid colon, by the way, both of which are mobile. Now remember, sometimes this also you should remember this, especially if you're going for postgraduate. Now, if there is not enough length, remember what are the things you have to do before doing an anastomosis. Three things are very important. Number one, you have to check the blood supply. The anastomosis must be tension free, and you must use the correct materials, right? So if you cannot do, sometimes there's very short sigmoid and the transverse colon is not mobile enough. In those cases, you have to remove from the cecum up to the distal part of the descending colon, or up to the sigmoid, that is subtotal colectomy. This is sometimes, most of the times we don't need to do that, but if the transverse colon is short or immobile, or the sigmoid colon is very short and you cannot bring them together, then you may have to go for subtotal colectomy and do an iliosigmoid anastomosis. The ileum will be brought down with the sigmoid and anastomosis will be done over here. But you don't have to know that. At undergrad level, just remember left hemicolectomy is the surgery, what you want to do. Left hemicolectomy. The name of the surgery is left hemicolectomy. So at undergrad level, I think this information is enough, that if the examiner asks you what surgery would you do if the cancer is in the left colon, so I'd like to go for a left hemicolectomy. And if sometimes if they ask that if you cannot do the anastomosis, that means the examiner is asking for, then what would you like to do? Then such subtotal colectomy is the only choice. You have to go for a subtotal colectomy, but this is very rare, very rare. Most of the times, left hemicolectomy is what we do. Actually, in my life, I've only done once a subtotal colectomy. In 90% of the times, always left hemicolectomy is the answer. Again, if the cancer, this is what we're just talking about, if the cancer is in the descending colon, go for left hemicolectomy. What are the vessels divided? Inferior mesenteric, left colic, and some of the sigmoids. If it is in the sigmoid colon, then it's called high anterior resection. Not in the sigmoid colon, usually in the distal sigmoid colon. If it is in the sigmoid colon, we can go for a sigmoid colectomy as well. But in either cases, you have to go for a left hemicolectomy, because if you remember the descending colon is actually a fixed structure, right? For example, if this is the tumor is in the sigmoid colon, you have to go for sigmoid colectomy. But you cannot bring the descending colon to the rectum. That's why you have to mobilize the splenic flexure. The splenic flexure. These are actually difficult terms. I don't think you have to remember at undergrad level. These are not very essential. Just remember, if a patient comes to you with malignancy in the left colon, you say, I'll go for a left hemicolectomy. Left hemicolectomy followed by anastomosis between the transverse colon and the sigmoid colon. That's good enough. Sometimes we can also go for anastomosis between the transverse colon and the rectum as well, if the transverse colon is very, very mobile, but usually it is not very necessary. And if it is in a sigmoid colon, then it is called sigmoid colectomy. It is called sigmoid colectomy. Remember, always you have to go for oncological clearance. Wherever the tumor is, you have to go for oncological clearance. If it is in the rectum, you remove the rectum together with its mesorectum, and then high ligation of its vessel. which is the inferior mesenteric artery. If it is in the right colon, if it is in the cecum, then you have to go very high ligation of the ileocolic artery. So always remember for oncological clearance. Another procedure, for example, sometimes the tumors are very advanced tumor. Sometimes you have a very advanced tumor. For example, if the patient has a very advanced tumor and you have a very, for example, the tumor is here and it's completely obstructing. Tumor is in, let's say, in the sigmoid colon and it's completely obstructing. So what is happening is the proximal colon is very dilated. Distal colon is not that dilated. So if you resect this part and anastomose this part with the distal part, there is a size discrepancy and there is always a chance of leakage. So in this case, what we do, we resect the tumor if it is possible. We resect the tumor, close the distal stem, close it, and bring the proximal stem as a colostomy, end colostomy. So what are the things we are doing here? We are resecting the tumor, closing the distal stem and doing an end colostomy. Now this is called Hartmann's procedure. This is called Hartmann's procedure. That is proximal end colostomy, overswing the distal stem, and usually we do the reversal in 4 to 6 months. Now remember one thing, reversal is extremely difficult. Reversal of Hartmann's procedure is very, very difficult. So any of you who are going for a reversal of Hartmann procedure, make sure you have enough expertise, because it may sound very easy, but actually in practicality it's very, very difficult. Primary anastomosis is rarely done in obstructing colonic carcinoma. We usually go for subtotal colectomy with ileosigmoid or ileorectal anastomosis. Postoperative care. Now, postoperative care is usual. We give antibiotics and other things, but one of the gravest complications is anastomotic leak. Usually doesn't happen. I have not really seen any anastomotic leak, but it can happen. Probably there's sometimes partial, sometimes complete. Now, if it is partial, you may go for. How would you understand the patient is having an anastomotic leak? Now, there are two things. If you remember, we may go for a proximal ileostomy. Sometimes a proximal ileostomy is done. Now, if you do a proximal ileostomy and if there is an anastomotic leak, it's usually not a big problem, because all that is coming out is a bit of mucus and a bit of stool, and usually antibiotic works very well for that. But if the anastomotic leakage is complete and if there is no proximal ileostomy, then you must go for laparotomy. How would you understand that there is an anastomotic leak? Patient will usually initially have localized pain. Localized pain when? Usually at around 5 to 7 postoperative day. During the 5th to 7th postoperative day, there is localized pain and fever. Then there will be tachycardia. So if these features are like this, then there is a chance that there is an anastomotic leak. If you go for investigations like CBC, there will be increased lymphocytosis. There is the lymphocyte count, leukocyte count, will increase. There will be neutrophilic leukocytosis. So once you see all these things and you start antibiotic immediately, you start a different batch of antibiotics, usually broad spectrum antibiotics, you follow up the patient closely. Now, if you see the patient is deteriorating, that is increasing pain and all other features, then you have to go for a laparotomy. After laparotomy, you go for a thoroperitoneal wash. What you can do is you can go for an end colostomy. You can go for an end colostomy, and that is probably the safest one. If there's an anastomotic leak, probably the safest thing to do at undergrad level, I think what you should say is go for an end colostomy, and then oversee the distal part. And when the patient is stable, maybe after a few months, then we go for a reversal. It's quite similar to that of Hartmann's procedure. Certainly after the operation, if it is an advanced cancer, you may have to go for adjuvant therapy. If it is very advanced, new adjuvant therapy, I've already discussed about those things. Chemotherapy. Usually, remember, in case of colonic malignancy, chemotherapy do not work very well. Chemotherapy works very well for rectal CA. But in case of colonic malignancy, chemotherapy is usually not very effective. If it's an advanced case, with liver metastasis, talk to a hepatobiliary surgeon. He may go for liver resection or other forms. Chemotherapy is another option. If there's disseminated metastasis, chemotherapy is the only option. Few things I would like to discuss. Remember, many of the colorectal malignancies can be avoided over the age of 50 due to regular screening test. Right? So regular screening test is something we should start in Bangladesh. We the next generation of doctors should be thinking about this regular screening test. It can be in the form of colonoscopy or cheaper tests like occult blood test can also be done. But some form of cheap screening test must be started. Most colorectal cancers start as polyp. Very important. And if you have polyps, usually you may not have symptoms. And it is the most preventable cancer. It's preventable. That means you can prevent it before happening by doing screening tests. This is very important. If you can remove the polyps, before they can turn into a cancer, the cancer is prevented. There's no chance of cancer. So screening test has to be done early. And if you can do it, the survival rate is more than 90%. If you can treat the patient at stage 1, the survival rate is 80 to 90%. So this is very good. 5-year survival rate is 80 to 90%. If you do the operation in stage 2, it is 70%. If you do it at stage 3, it's below 40%. If you do it at stage 4, it's less than 10%. So you can understand what you can do if you can do the operation at an early stage. So that's why screening tests should be started in Bangladesh as well. This is the third most common cancer nowadays worldwide. Happens to both men and women. And those colorectal, if you are interested in colorectal surgery, it's very good news because tremendous strides have been made regularly for prevention, diagnosis, and treatment of colorectal cancer. And if you want to be a clinician, you must stay abreast of most of the recent advances. Every day it is changing. Every day it's changing. So anybody who is interested in colorectal surgery, you can definitely come to this. And in Bangladesh, the prevalence is rising. Both males, females, young and old. Everybody is being affected nowadays. Yesterday night, we have done an operation. The patient was most likely 35. No, yesterday this patient was actually 51, 50 years age. The day before yesterday, the operation we did it actually something around about 31 or 32. So as you can understand, it's very common nowadays and very high in demand. So those who are interested in colorectal surgery should come into it. In Bangladesh, we have got very good programs, MS and FCPS is also being started. So you guys can come. You can also go for training in different countries. Go for that. It's a good idea to go into training, get the training, short trainings, not long. Don't go for 5 years or 6 years of training. Short training, come back to Bangladesh and start your practice, and that's a good way of learning. So thank you for your time. Next week, let's see, maybe we will go for inflammatory bowel disease. Maybe. Let's see what happens. Thank you for so much time for your time.